I'll turn a couple of minutes over to Lupita to talk about our melon initiatives, and then I'll pick back up from there.
Hi, thank you, Brandon. So I am a graduate assistant for the Mellon Humanities Now program. And basically, it's a program that helps students who are interested in transferring from CNM or any of the UNM branch campuses to UNM. It helps with the transition by providing mentoring and any sort of guidance and resources. And as a graduate assistant for Latin American studies in particular, we offer a lot of workshops and events, such as this one. And one of the things that we do at Mellon is provide a summer academy, I believe for 6 weeks, where students have the opportunity to take courses that can be applied to their associate's degree and their bachelor's degree. And they can be like transferable credits. And then upon completing the summer academy, students are granted a $2,000 stipend and also an iPad. And some of the things that we do, particularly in Latin American studies, are offer workshops, and we also offer indigenous languages such as Nahuatl, Quechua, Yucatec Maya, and Portuguese as well. And there's also funding and scholarships for these languages, which CNM students can apply to for the summer. So I will put my email if anyone is interested in learning more about Mellon, or if they're interested in transferring, I can help with that process as well if you have any other questions. Thank you.
Thanks so much, Lupita. All right, so it's going to fall to me to introduce our speaker today, Anne Kraemer. We're very happy that she was able to join us. I always call her my partner in crime, but my partner in doing study abroad, her name is Dr. Jessica Craig, and she's an anthropology instructor here at CNM. She's trying to join us, but the Zoom gods are not looking favorably upon her. So I will do my best to see if I can get her in after I do the introduction. But she actually knows Anne, and when we were in Guatemala with our student group back in August, I was able to meet Anne and get to know her a little bit. As you may have read on the flyer, she is an anthropologist and a co-founder of the Maya Health Alliance. And I'm not going to try to pronounce it, I'll let her do it. But this was an organization created in 2007 to address health issues in rural Guatemala. She served as the executive director and CEO since 2009. And I'm very excited to hear more from her about the Health Alliance and about the work that she's been doing in Guatemala. So with that, I will turn the time over to you, Anne.
Great. Thank you so much, Brandon. And hopefully Jess will be able to join us soon. She having Zoom issues these days. It's wonderful to meet all of you and join the work that we're doing, join with you and share with you the work that we're doing here in Guatemala. Just to give you a little background first, I studied anthropology in undergrad, and then I went on to do my master's in anthropology and was starting the PhD process when we started a nonprofit. This was never my plan at all. I was very interested in coming to Guatemala to really understand indigeneity, really understand the culture, the people, understand why there's so many nonprofits in Guatemala. And I never dreamed I would start a nonprofit. Things just came together. The community asked us to help them provide healthcare in their language. And so things started little by little, and 17 years later, here I am. So what I'm going to share with you is a little bit about the work that we do, and feel free to have any questions at the end, and I'm going to share a video with you guys at the end as well. I'll just send you the link because sharing videos over Zoom is really bad for everyone. So I'm going to share my screen just because I think it's really important that you guys can see Guatemala if you haven't been able to be there. I think it's so much more fascinating to see the country and the people who we work with and who we serve. So Wuqu Kawoq, or Maya Health Alliance, We're really working to transform health in rural Guatemala, and we believe it's really fundamentally important to be led by the community and to use data at all times to help us inform and learn from the work that we're doing. So Wuqu Kawoq, we work in central Guatemala. So on the map that you can see, we work in 9 different departments, which departments are sort of like more like the size of counties in the United States. Guatemala itself is about the size of Ohio. It has 18 million people in it, and we serve about 10,000 of those people every year. We have a team of over 100 people. And every day we're working to serve more people across the country, but we really want to do it in the most strategic way possible. And as an institution, when we really began in the community. And I think that's what's really important about the work that we're doing, is we're not trying to bring a top-down, you must do it this way because this works in Chicago, so we're gonna, do it this way here in Guatemala. Not at all. The work that we're doing is informed by the communities, it's led by communities, and importantly, in the picture that you can see on your screen, you wouldn't know who our staff member was. The only reason you know who she is because she's holding the little informational packet showing the family. Because we really focus on hiring and empowering, especially local women, to be nurses, to be community health workers, and work in their communities. And in Guatemala, an interesting fact is that there's 22 indigenous Mayan languages spoken here, plus Spanish, plus Xinca. And so with all of these different languages across, just an area the size of the state of Ohio, you can imagine that it can be difficult. I would say now, today and age, Spanish is definitely 50% of the population. But there is a large population, especially women and children, who don't speak Spanish, or that a Mayan language is their first language. And especially when you get out into the rural regions of Guatemala, you often encounter women and children and some men who don't speak Spanish at all. So imagine going to your doctor or your nurse or your healthcare provider and you can't speak to them at all. That is often the case here in Guatemala when you think of anyone in the rural communities trying to go and receive services at the Ministry of Health. So when we began back in 2007, community members came to us. There was 4 of us who were learning Cachiquel Maya, one of the languages. And they said, help us out. We're really interested in providing quality services in our language. Because the Ministry of Health here in Guatemala, while they do have buildings, they do have nurses and doctors, most of the time, it is not in our language. It is only in Spanish. And most of the time, doctors are discriminatory, they're racist towards us, and we don't feel safe to go to the clinics. And so that's a key point. Why don't they feel safe to go to the clinics? Well, in Guatemala, we have a massive challenge that we're facing. And that's really that Guatemala is one of the most unequal nations in the world. Importantly, Guatemala is not a necessarily poor country. When you look at its GDP per how big it is and how many people it has. In general, it is the wealthiest country in Central America over Costa Rica. It has an extremely large export economy, especially around bananas, coffee, and sugar. It has a growing middle class. However, it is extremely unequal. And the indigenous Maya, especially women and children, really feel the brunt of that inequality. So barriers that we're trying to overcome are often focused on language, distance, cost, and mistrust. And you might think, well, where does some of this mistrust come from? Well, in Guatemala, there was a 36-year civil war that ended only in 1996. And oftentimes many people really feel that pressure from the Civil War because it wasn't actually a civil war. It was more of a genocide, as stated by the UN. Over 200,000 people were killed and over 1 million people were displaced from their homes in Guatemala. And the majority of those people were indigenous Maya people. So many people had to move, find new homes, redo their lives. Many people escaped into Mexico because often what was happening is government troops were going into communities and tearing them apart. And so, as you can imagine, that can be really distressful for community members to trust the government services. Also, the health gaps that we're working to overcome, there are many, but I'm just going to share a few with you. Nearly half of Guatemalans speak a Mayan languages, but as I talked about, most healthcare is delivered in Spanish. Also, 47% of all children under 5 in Guatemala suffer from malnutrition, but over 70% in rural and indigenous communities suffer from malnutrition. So Guatemala has the worst rate of malnutrition in this entire hemisphere, worse than Haiti. And we know that often Haiti, unfortunately, suffers from many issues. But Guatemala really is very high in malnutrition. Yet we know that Guatemala has amazing agriculture. They grow corn and beans within their, small plot farms. And we have many vegetables such as carrots and sugar snap peas and broccoli that is grown all over the highlands, and many are exported to the United States for our frozen food market. However, many of the families themselves don't get to eat that food. And so that's something that we're really working to overcome. Also, the rate of type 2 diabetes is exploding. And that's directly related to most Mayan people being malnourished as children. They're much likelier to get type 2 diabetes in their 40s and 50s. Also, Mayan women are 3 times as likely as non-Indigenous women in Guatemala to die from preventable pregnancy-related deaths. And overall in Guatemala, you're 16 times more likely to die here in childbirth than you are in the United States. So we can see that childbirth is a really dangerous situation for women here. And that's something that we're really working to overcome. There are more health gaps, but that's just a really general big picture of some of the main ones that we're focusing on. So how do we overcome some of these issues that I've presented? Well, our key piece is to collaborate with community health workers, patients, and communities. And we do that by really focusing on community-led. So working within communities. It's not an easy process. It's not a fast process, but it is a process that works. And we often work with what are called cucoles, or community development groups. And we listen to them, we understand their needs, and we talk about the services that we can provide and how we can share data with them and what that will look like over 2, 3 to 5 years. And we hire community health workers from that community or from that region that speak their language and that also understand the barriers that their patients are going through. So for us, it's really key that we're training Guatemalans to serve other Guatemalans, that it's not always people who look like me that are coming from the United States to serve people here. We are not a group that really focuses on white saviorism. That is not what we are. That's not what we want. We want to help communities be resilient, to be who they are and have the future that they want. If we're not doing that, then we need to get out of the way. So our solution is to really work alongside communities, provide a lot of capacity building to community health workers, and then help provide the infrastructure so that they can get to work. And oftentimes, as I've been talking about the community work, the communities we work in invite us to be there. We're not imposing, they want us to be there. We work with the traditional leadership structure, and we often focus heavily on women. As we know in Guatemala, there's a lot of machismo, or the idea that men often hold all the power or are over women in many situations. So we're trying to slowly make changes to help women realize the power that they themselves have and all of the, great things they can do in their communities. But oftentimes they are limited by their husbands. But slowly, in some communities, we are making inroads. And oftentimes that happens through our staff. So as you can see in this picture, there are women doing a cooking class for one of our nutrition programs. And the staff member is the one in the red sweater. And what is so important is that she's from the community. She's working with them. They're women sharing time together, being able to talk about life, talk about problems, and also learn about nutrition and cooking together. And I know it seems like, well, don't they do that anyway? And I have to say that no, a lot of times women aren't allowed to get together. Their husbands will tell them, you can't leave your home, you have to ask permission. And so having that reason to be able to leave their home, get together with other women, share time together is so important. We're creating community, we're fostering community, and in some cases, we're helping to slowly change certain cultural norms as the communities want and are ready for them. In order to really demonstrate how our work is done, I think this program really demonstrates it quite well. Because our goal is not to tell people how to live or tell people what to believe about their health. We really want to support people in understanding their healthcare, the world around them, and providing better health outcomes. We want to save lives. So our mobile maternal and infant health program is a really great example of how we are working within the culture to provide certain tools to help save lives. So within this program, we work with traditional midwives, and the traditional midwives in Guatemala oftentimes are women who are called to be a midwife. So it's often something that happens in a dream or happens in their life path. They're called usually by God to become a midwife, and then they train through apprenticeship in order to learn how to be a midwife. Oftentimes their mother or sister, an aunt is already a midwife. And so they really find it as a very important calling to go serve other women. Oftentimes their forms of payment that they receive from their patients can be a little bit of cash or chickens or fruits and vegetables, because often the patients themselves don't have a lot of money to pay for their services. The midwives themselves are incredible women. Most often they speak the Mayan language from where they're from. In this project, we mostly work with Kachikel speaking women. And what we've done is we've created a cell phone app that speaks in their language and basically helps midwives to detect high-risk pregnancies before it's too late. And you might think about, well, why don't women just go to the hospital? Well, as we've talked about, many women don't want to go to the hospital. Oftentimes they're really scared to go to the hospital. They might not speak any Spanish, and they might be 3 or 4 hours away to get to the hospital. Even though the mileage isn't that far, when you think of these mountain roads, sometimes they're up and down many hills, they're dirt roads. It can take several hours to get to a hospital. And if you're scared, if you don't trust the health system, you don't want to go to the hospital. And I think something that really got me many years ago when we first started this work back in 2007 and 2008, I did focus groups, I did interviews with some of our 2B patients and some of the communities and community members. And I asked people, why do you want a doctor or a nurse to speak your language? And they said, well, of course, I want to be able to share with them. But also, I don't want to lose my language. So it was really interesting that people themselves who we were interviewing found that being Kachikel, that being indigenous, it's important. That language is part of who we are. It's part of our medical care. And then lastly, people would tell me, you know what? I'd rather die at home than go to the hospital. Think about that sentence again. I'd rather die than go to the hospital. That's really drastic, but that's how people in Guatemala feel. Because of the racism, because of the discrimination, because they say, I don't want to be left in the hallway. I don't want to be left on the floor. I don't want to see other people being accepted in front of me, even though I'm hurt or I'm suffering or I'm giving birth in this moment because I'm indigenous and that person's not. So you can see there's a lot of barriers that we're dealing with. So we work with midwives and we train them because there are situations where women do need to go to the hospital. Most women birth at home and they're fine. But there are times during preeclampsia or during hemorrhaging or other complications that they should be at a hospital so they can access more care to have their baby. So the baby and mama are safe. So what we've done is make this app, which you can see on the bed laying next to the woman. Basically, it's a picture-based app because most of our midwives never went to formal schooling. They don't read or write. They do speak Kachikel, and they're incredibly industrious women. So with the application, basically this picture-based app helps them understand, does the woman have any, symptoms that would be high risk. And we also provide them with a blood pressure cuff so that they can understand, is preeclampsia an issue or high blood pressure for this mother? When problems do arise during the birth process and we need to send a mom to the hospital, our nurses are on call 24 hours a day. So if a midwife has a problem, the phone that the midwife has will automatically call our nurse, and the nurse will, decide, does the woman need to go to the hospital? What do we need to do? And if she needs to go to the hospital, then there's a process of convincing her husband and the woman herself in labor that you need to go to the hospital, because sometimes the husband or the mother-in-law won't let the woman leave. Sometimes the woman herself does not want to go. So we've provided care navigators. Care navigators are women who speak Spanish and Cachiquel, and they go along with the pregnant mom in the hospital, and they stand by her the entire time. It doesn't matter if she gives birth naturally, if she goes in to have a C-section, she is there the entire time. So we've worked really closely with the Ministry of Health to make sure that our navigator can be there the entire time. And we're really happy to say that the outcomes have been fantastic, that we've been able to save lives due to this amazing process of having midwives being able to detect high-risk pregnancies and having the care navigators in the hospital to really increased and improved health outcomes. I think what's key is that right before we started that, there it is. I thought I had a graph. It was key that when we first started this program in 2016, right before as we were designing the application and designing this program, there were 8 maternal deaths in the region that we are working. And as you can see, the blue bars demonstrate how many births we are attending during the year. So averaging between 500 and a little over 800. And then in the white numbers are the number of deaths that we have had in each year. And so we're very proud to say that since 2016, we've only had 3 deaths, when in 2016 they had 8. So, for us, that's absolutely fantastic. It's a wonderful outcome. The Ministry of Health themselves are very excited about it. And I'm very excited to share that we just got a grant from Google, and we're going to have $1.8 million with our partners at Emory University to create an artificial intelligence piece to this application that will basically help predict through machine learning the outcome for the infant by listening to the infant's heart rate while it's still in the mom. Because over the last almost decade, we've been recording baby heart rates and trying to understand if they're having intrauterine growth restriction. Because if we're going to have healthy moms, we also need healthy babies. And so we need to know how they're progressing through through the entire pregnancy. So this is a new opportunity for us. And what we're really hoping is that we can create this application, this phone application that will be really fantastic to understand mother and baby health. And then we hope to scale it across to other parts of this country, because it's really been a positive piece to see how we can maintain the culture, the language, and also help women access safe birthing care. Another program that I think demonstrates this is our family-centered nutrition program. And so I already hit on kind of pieces about malnutrition being a major issue here in Guatemala. Similarly, coming from maternal infant health, we need healthy moms and babies in order to really turn around this malnutrition issue. But oftentimes what we're seeing is children by 6 months of age are already falling into being malnourished. In Guatemala, importantly, what we're seeing is not often what you see on the TV version of malnutrition, where children are literally starving to death and you can see their bones and their distended bellies. In Guatemala, what we have are children who are short for their age. So on the left are children who were born in a part of Guatemala, and you can see the blue line above their heads. That's the World Health Organization's height line, average height line for children who are 9 years of age. On the right are the cousins of children on the left who were born in southern Florida. And the height line, it's kind of hard to see. It's pretty light blue, but it is behind pretty much all of their heads or right above their heads. So what is so important about this picture is to say that Mayans themselves are not short due to genetics. This is a social disease. This is not a disease of genetics, but basically because people don't have access to clean water, to good sanitation, or, good bathrooms, because they don't have access to good roads, education, enough food, people are basically short for their age. And what does that mean, being short for your age? Well, often what is directly happening between age 0 and 2 is our brains grow more than any time it will grow in our lives. And so it's a very important time to have the right calories, because when we don't have the right calories, our brain doesn't grow and our bodies don't grow. And so what we're seeing is that we're not getting the right calories into children between 0 and 2. We are going to directly affect their entire life outcome. Obviously, I'm using statistics to talk about these big pictures. There are outliers, but in general, if you are malnourished, in general, you will have worst overall life earning income possibilities. Why? Because often that means you're going to drop out of school earlier because you weren't able to focus as long. You're maybe behind on reading, maybe you're behind on writing. And so this is really important that we focus between ages 0 and 2. So our approach in our program is to partner with caregivers. We do not regañar is the word in Spanish, but we do not scold caregivers. We do not say it's your fault that your child is sick. It's your fault that your child is not growing. We do what's called motivational interviewing, and we talk with parents, and we want to motivate them to say, hey, what can you do? What do you want for the future of your child? How can we help you get there? We don't want them to feel bad about what society, about what culture, about what the country has put upon them. We want to empower parents to do the best they can for their child. We focus on that first 1,000 days, which is during pregnancy, and then through the first 2 years of life. It's a personalized care plan. We spend 6 to 8 months with every child, depending on how they're growing. We do workshops. We provide food supplements such as eggs, beans, and like a peanut butter packet with micronutrients. And we do ongoing weight and height monitoring, as well as in-home workshops, and we provide access to women's health as well for women. And I'm proud to say that we've had really great results with our program. In this controlled study that we did in a small population, we were able to reduce malnutrition by 40% over 4 years. But importantly, what I want to point out is the government has not been able to reduce malnutrition by more than 0.5% ever in Guatemala. And in fact, unfortunately, malnutrition went up during COVID. And while our results here were pretty fantastic, it takes time. And this is not an easy process. There's no one pill that you can give a child and say they're all better. It takes time, it takes education, it takes, the family really choosing between how much money they have and what they can provide their children. It takes ongoing time for the mom to cook, learn recipes. It takes dedication. It takes a lot of staff time, a lot of education. So it's not easy, but we can see fantastic results. And just to share a couple pictures of our team in the field, weighing and measuring babies, and this is all done on a house-by-house basis. So we're serving over 1,000 children per year. And as you remember, we're doing this for 8 months for each child. So that can be 8 to 10 to 15 to 20 visits per child, depending on the child's growth and how they're doing and how sick they are. Sometimes they have to go get medical care. For some families, we provide water filters. There's a lot of pieces to this puzzle. And I think importantly, I really want to give an amazing shout out to our team. We can't do this work without the amazing health workers that we have. And oftentimes this work is really solitary. So here's one of our nurses out in Quetzaltenango, and she is carrying a big measuring board, walking from house to house. And oftentimes she'll take a bus or a tuk-tuk or the back of a pickup truck in order to get to her families. But I want to say our staff is so dedicated to the work that we're doing. They're from these communities. They want to see change. They feel really excited about their work they're doing. And also, I think what's doubly important is the impact that we're having, not only on our patients and our communities, but also by paying our staff, because our staff then can go home and pay for things for their children or make decisions for their family. And that's also really important to us, is that we're building capacities in Guatemalans to serve Guatemalans. So just also to touch on our women's health program, we also go house to house, and it's really key because I've touched on a little bit on the pieces of machismo, or this idea that men are really control women. As you can see, our health workers here speaking with 3 women as they're weaving. And this is often something that we do as we go to the home. We find women where they are. We go to our patients because we often know that patients aren't going to come to clinic because of all of these, barriers such as traveling distance and costs and fears. So in our women's health program, our approach again is providing access, support, and education. And in this picture is Susie, who I'm going to send you a video so you guys can meet Susie and get to know her a little bit better. She is the manager for our women's health program, and she's an amazing woman with an amazing story. She came to us as a nurse almost 8 or 9 years ago, and she was very quiet and meek, and it's just amazing to see her now giving out condoms and telling people how to have protected sex and how they need to live their lives in a better way. Like, it's just amazing to see what she's doing to change her community, to empower a team of 30 nurses to provide free birth control of many different types across, a major part of the country, as well as provide cancer health screenings, cervical cancer screenings. So our family planning is people can choose from any type of long and short acting method. We go to your home. So as you can see, our nurse on the left is putting in an implant that will last for 5 years in the woman's arm in her home. And so that's something that's pretty important. How amazing would that be for your nurse to come to your home and give you your IUD or your implant? But we know that that's where we're going to meet women, and that's where we have really high positive outcomes. And we have a really great follow-up procedure to call women, make sure that they feel safe, secondary effects, so that they know that these are normal. Another key piece, as I've touched on, is gender equity and inclusion. Guatemala has the worst gender equity gap in the Americas. That's that machismo thing I've been touching on. It's really real, and it's really difficult. So we've started working with a male peer educator to help engage men in different ways. As you can see here, our male peer educators on the left, and he's worked with police officers, he's worked with Army, he's worked with community development groups, partners, soccer teams, basically going to find men where they are and talk about safe sex, talking about, partnerships in a marriage, that you can have a partnership rather than top down. It is a process. It's not quick, but it's something that we're really working on so that men and women together can make decisions about how many children they want to have, about what kind of relationships they want to have. We've seen great success in this, and we want to keep growing that part of our program. Another key piece is cancer prevention. Cervical cancer in Guatemala, unfortunately, is the #1 cancer killer of women in Guatemala. And it's very rare in the United States that kills women because so many women get their pap smears. It's very common for women to get their pap smears. Even so much now, women are getting HPV testing, which HPV testing is even more accurate and is really like a crystal ball to see if you're going to have cervical cancers or at least cervical lesions. We have recently finished our microbiology DNA lab, so we will begin HPV testing for Indigenous women next year. We're really excited about that. It's state-of-the-art care that's provided in the United States, and we say, why can't it be provided here for Indigenous women? So we're really excited to be starting that, providing that incredible service in a country where cervical cancer really has such a high impact on women. And when we do find women with cervical cancer, like in this picture, that's one of our health navigators taking one of our patients to the cancer hospital so that she can get follow-up treatment. Because unfortunately, oftentimes women are found when they are pretty far along in their cancer, because oftentimes cervical cancer can be a little bit of a silent killer. And we're happy that we can provide those processes such as radiation, chemotherapy for women before anything is too late, because often, as happens in the United States, in Guatemala, women put their children first, they put their business first, they do everything first rather than care for themselves. And so we're trying to let women know that we're going to help them care for themselves. Another kind of special, unique thing that we do is pediatric care that's really specialized. Here in Guatemala, there's a lot of, I shouldn't say there's a lot of children, but the children that do have, you know, Down syndrome or a genetic disorder or something that's out of normal are often hidden at home. They often cannot find any care throughout the country. People don't know where to go. They can be shunned. Why does your child look like that? Why can't they talk? And so what we've been able to do is connect children here in Guatemala with services, with therapy, with food, depending on what they need. And it's been really important. I want to share a couple of pictures of a couple of our children that we've been serving, just to kind of give you an idea of different issues that they have. On the left is Michelle. And Michelle, when we met her, she was quite little, only about a year, and she wasn't able to sit up because she has a disorder that is congenital, that is a brittle bone disorder. And so basically she wasn't even able to like support her body weight because her bones were so brittle. In this picture, Michelle is now 6. She looks quite little, but that's just really the situation of her disorder. And we're able to get her the medicine and the care she needs. And now she runs everywhere. Without the medicine, without the care, she would not be able to walk. She would not really be able to move because it's like her body's fighting against her. Daniel, the second little guy, he was born without an esophagus. And so there was no way he could eat or really survive. He had an emergency surgery when he was born in the hospital, but it wasn't all the way completed correctly, unfortunately. And the mom went home and the baby was not thriving. She was connected with us and we've helped him get further surgeries and helped him get all the formula so that he can grow and be strong. And the mom is a very young mother. She's only 19. She was very confused, feeling quite lost, as any mom does, but also being so young is so difficult. So we're really happy to see Daniel growing and thriving. And Rocio in the third picture, she is a lovely young lady who she's now 13, and we met her when she was about 2 years of age. And she suffers from a situation where she has epilepsy because of tumors that grow throughout her brain kind of constantly. Even if you remove them, tumors will keep growing. So she suffers from epilepsy. She doesn't really speak. She can communicate with her parents, and sometimes she can walk depending on her day and how she's feeling. But her parents were really concerned about how to care for her, about everything that she had going on. And we were able to connect her with neurology department here in Guatemala to be able to provide the medicines for her epilepsy, and also to let the parents know that this was a very rare disorder and they could have another child. They waited for 7 years, but they now have another daughter, and they feel very happy that they can take care of Rocio, but they can also have, the right advice to have another child. And then Jose on the far right is a little boy who was actually adopted by his parents. He was kind of given up because he does have several disorders. He doesn't speak. He is not able to walk, and he has a lot of learning disorders. Even though he was not growing well, his parents were not able, the parents who have him now, were never able to have children. And so they adopted him, and they're thrilled with how he's doing. We help provide him with therapy in a center here that does therapy for children with these kind of conditions. And they're just thrilled that we can help provide him with formula that keeps him growing, that he's able to have certain interactions, that he's able to communicate in certain ways, and that he has a happy, loving family. And so I think it's really important because sometimes these are the forgotten children that don't have access to care and that otherwise would not have any care and might be hidden at home. Just to touch on quickly, some of the work that we do is we do a lot of research that is funded by the National Institutes of Health in the United States. We currently have 5 R01s that we're working on right now. We publish extensively, and a lot of our work is really to understand health in Guatemala and population health. And we use a lot of that information in order to inform our programs, because we don't want to just create programs and say, well, this might work. We really want to use science and implementation-based evidence and information to give the information to our projects and our programs so we know that we're doing the right thing. And that's why we're data-led. We collect a lot of data and we constantly are using that data to better our programs. We've done several clinical trials in malnutrition to really understand that the nutrition project we are doing now, that program, works, as well as around our education processes in women's health and diabetes. And we're currently doing several projects right now around early childhood education and kidney disease. So thank you so much. I will send you guys my link right now really quick to see the video so you guys can meet Susie. But I would love to open up to any questions about the work that we're doing here in Guatemala.
Yeah, thank you so much. I'm sorry I was late. I have 3 laptops right there. I'm trying to get one to work. Thank you. Thank you for being here. Brandon, you were able to introduce Anne, so everybody got to hear how awesome she is. In case now they definitely know how awesome you are. It's amazing work. So I am happy to read questions. If people have questions they'd rather type in the chat, or if people want to do that little raise your hand thing, that's totally fine too. Whatever works. If you have questions, let us know.
I'll send you guys my website so you can check it out as well. So what kind of qualifications do you have to be a part of this? Well, I'm an anthropologist, never finished that PhD like Jessica did. So I was doing my PhD research to start this, but I think, qualifications is, we have lots of different people. We have people from all different kinds of backgrounds, both Guatemalans, Europeans, people from the United States who help us in many different ways. We have board members who have backgrounds in business and IT. We have people here on the grounds that are community leaders. We've had volunteers who work with us who are in communications, who are anthropology, public health. So lots of different ways. There's lots of different work to be done here to help in Guatemala.
And I did have a question about, I think the answer is kind of obvious, but with the contraception, like with the contraception work sounds weird, but that's basically, is it in terms of machismo and just like, do you encounter, not you, but the folks working for you and the women that are kind of working with you, or do they encounter more pushback in that arena from their sort of male partners?
Yes. That's a definite yes. I would say in some communities, they're getting more open to it. We've had a couple of cases, very few, where the husband and wife come together and say, we want to plan for our future. But often cases, our nurses are helping women hide their method. So oftentimes they do the shot, the Depo-Provera, which is 3 months, and it's very easy to hide a quick injection. And we'll visit women at their work, in their market, and wherever they are, do the quick shot, and they're done. And we don't always want to be that way, but we want to help women have the choice that they need. And so right now, if that's what we need to do, then that's what we will do. So yeah, there is definite pushback. We've worked in rural communities where we were giving a class and all the men were standing around like this, waiting for us to leave and told us not to come back. So it does happen. It doesn't happen in every community, but it's sort of a slow process.
Mike says, thank you. Great information.
Safety concerns for the nurses. Yes, there are. So I don't know if anyone's aware of what's happening politically in Guatemala right now. It's sort of exploding. Basically, right now, we just went through 21 days of blockades, over 200 blockades across the country. Because democracy is really at threat right now. And so there's a lot of political situations going on. So we had to sort of close down a lot of our work because our nurses literally couldn't move because there were so many blockades, and some of them wanted to protest in support of the new president-elect. So that was a situation that just happened. But in general, our safety concerns for our nurses are robberies, mostly like pickpocketing type of thing on buses and things like that. We have had very few, but where like, what do you call it? A gun was involved in like saying, hey, give me your computer, give me your book bag. But usually it's more of a pickpocket. You don't notice someone pulled something out of your your book bag on a phone. that's usual danger pieces that we deal with. And then in some areas, it's very isolating, and our nurses will have to walk through sugarcane areas or coffee fields. And so we ask them not to go alone, and we work with community members to provide them escorts or have two women walk together so that they are safe, because unfortunately rape and things like that do happen when you're walking alone in these isolated areas of communities. So we want to provide them those safe escorts at all times. What towns and aldeas do we work in? We work in hundreds of aldeas. We work in 9 departments right now, the 9 kind of central highland departments. And we sort of work in different ways in different departments. But we sort of work regionally by receiving referral care for specialized patients. And then we work with many partner organizations in order to receive patients and cover communities. So that's a really big picture of the communities that we work in. What is the language learning process you all have? So for myself, I speak Spanish, and my Kaqchikel is really rusty. But for people who come volunteer with us, we would like them to be able to speak Spanish in order to work with our staff. Most of our nurses are bilingual. Some are tri and even speak 4 languages. Because they'll speak the community where they are from, they'll speak Spanish, and then sometimes around them there's several other communities who speak different languages. So some of our nurses are really incredible language speakers. And some parts of Guatemala speak mostly Spanish. So a couple of our nurses only speak Spanish. We sort of adjust to the regions that we're working in.
I'll ask a follow-up question to that one. Just in terms of language learning, what kind of support or process do you have for folks who are working for you who need to learn Kaqchikel or something like that?
So we in the past did a Kaqchikel class, and we're hoping to revive that again. So I'm going to let you know if that's going to be happening. We're hopefully I don't know if it's going to be summer 2024, but maybe 2025. We've worked with the University of Maryland in the past, and we're looking at another university that might be working with us to run Kaqchikel programming. It's like a intensive immersive course. For some of our staff, we haven't done a lot of language learning because they either know it or they sort of don't. And some of them, what we have provided are English classes. So we do have some of our, 7 of our staff right now are taking English classes. There's staff who are management level or directorial level. They're all women. And we hopefully want them to take over this organization in the future. And why do they need to learn English? Because if you want to raise money, you have to speak English, at least in the world that we currently live in. Great question, Michael. Yes. So we have collaborated with Peace Corps. We did receive USAID funding, USAID funding in the past. And we do work with many nonprofits. We collaborate with a lot of people. And I think collaboration, the number one thing you need is patience. A lot of patience and a lot of understanding. But I think as an organization, collaboration has really been key for our work since day one. We can't do this work alone. We are experts in certain areas in healthcare, but we need to collaborate with people who are building houses, who have clean water, who have stoves, who have educational access, who can provide financial opportunities. So we collaborate with a lot of other nonprofits that focus in those areas because we can't do it all and we don't want to do it all. We want to focus on healthcare and do it really, really, really well. We find everything else important, such as homes and education and financial opportunities and agriculture, but we can't do it all. So we really find collaboration as absolutely vital to the work we're doing. And we're talking to the Peace Corps again to maybe do some more work. So yeah, it's definitely an ongoing piece to the puzzle. And as far as the US government, Kamala Harris was here about 2 or 3 years ago. And since then, due to the heavy immigration from Guatemala going to the United States, there's a big focus from US companies to invest here. And we've been part of this discussion process with partners, but we don't really see a lot happening. Unfortunately, the funds are going up high and they're staying up high. They're not really coming down to focus on local work. We're hoping that things will change, but it's a slow process. Is there any protection for you all in regards to the government protection and what ways? yes and no. I would say in Guatemala, the police and military are quite different than the United States. Oftentimes the police in general are much less, their training is much lower than the United States. They often only have a high school degree, if that. And their protection for themselves is often much, much lower than a police force in the United States. So they themselves aren't always willing to like run into a situation, and I fully understand why. So I would say there is protection, but it's quite different than the United States. We really focus on keeping our staff as safe as possible. We have been doing this work for a long time, so we don't take, I don't think, unnecessary risk. We don't do a lot of advocacy. So we are fully a service provision organization. And while advocacy is very important, for example, we don't do a lot of that because the Guatemalan government has put laws into place that will quickly shut down a nonprofit if they don't like what the nonprofit is saying. So we have to be very careful about advocacy and really pushing to change laws or really pushing to change things. We really do it at a community level rather than at a policy level. The policy parts that we've been working on are really around malnutrition and things like that that have been identified by the government as an important piece of work. So yes, it is difficult to maneuver here politically. We're hoping for change. There is a new president-elect who is Bernardo Arevalo, who is center left, and is maybe the first democratically elected president since the 1950s. So our fingers are crossed, but he's receiving a lot of pushback and a lot of problems. I'll send you guys a link really fast. Because he's talking about there being a coup right now happening in Guatemala. And that's what I was talking about with all these protests and things like that. It's really a major difficulty. And we hope that the country can move forward without violence. And basically, that's like really the key piece, is that there's no violence. Because it's really key, because what happens here will affect the United States, whether it's through immigration, whether it's through more people coming in, and Guatemala is really tied economically to the United States. So yeah, we're going to hope that things transfer peacefully. Belize is sort of like a lost part of Guatemala. Guatemalans feel like Belize belongs to them, and Belize feels like they're their own nation. So they sort of do their own thing, and they're not really too friendly with each other, unfortunately. It's sort of like Guatemala feels like they lost their beautiful beaches to Belize. So not too much, because Guatemala is definitely much more populated and really has the economic upper hand with exports and things like that.
So we're almost at time. Are there any other questions? If not, we can wrap it up. But I don't want to cut anybody off if they've got one more burning questions. Oh, fun, happy emojis and thank yous.
Yeah, thank you guys for letting me talk at you for a little while.
Thank you so much, Anne. The work that you're doing is really incredible. And it's so nice to see your face.
You as well. Thank you guys so much, and check us out and come on down. We're down here.